It's great to be joined today by Dr. Shira Doron, who's the Chief Infection Control Officer for Tufts Medicine Health System and also the hospital epidemiologist at Tufts Medical Center in Boston. Really great having you on today. I appreciate your time.
Great to be with you.
So I've been reading all of these analyses and meta-analyses and meta-meta-analyses of what might be thought of as a simple question: do masks work to prevent COVID? And it seems as though even the most well-intentioned and sort of science-facing people have had different and sometimes changing perspectives on this question throughout the pandemic. There's also sort of a question of, what do we mean by do they work? And that might mean, what is the effect for an individual of their decision to wear a mask versus what is a policy of saying we require masking in these, those, or other situations? What does that do on the population level infection rate? So start wherever you want on this question, and then we can kind of go from there. Where are you maybe now on this issue?
Yeah, I mean, I think you hit the nail on the head, right? This is not a simple question. Do masks work? And where I am now is in many ways where I started before the pandemic was even a glimmer in our eye, which is that I've quite literally trusted masks with my life. My whole career, I have obviously worn masks in healthcare. I'm not a surgeon, so I've worn masks for my own protection, and I believe in them. I have taken care of patients with deadly bacterial meningitis in an ear loop surgical mask. I have taken care of patients with H1N1 influenza before there was a vaccine for it in a surgical mask. And I've taken care of patients with multi-drug resistant tuberculosis in an N95, and I have trusted it to protect me and keep me healthy and alive. And I still do to this day. But when the pandemic was bearing down on us, SARS-CoV-2, the COVID-19 pandemic, I started to have to really look at all of that literature because questions started to arise that were really quite contentious. The first question was, should we be using surgical masks or N95s to take care of these suspected COVID-19 patients?
Yep.
That was a really difficult one because we didn't have nearly enough N95s available in this country to take care of every person with a respiratory infection in the winter in an N95. And so we really needed to start looking at the data, which suggested that it wasn't clear cut whether you needed an N95 in that situation. And the CDC was really kind of hedging on its language. The WHO was being very clear that you did not need an N95. And so you may have seen that there was relatively recently a clinical trial that assessed N95s versus surgical masks. They started back in those days when we really didn't know what to do and didn't have enough N95s, and actually found that they couldn't detect a difference in healthcare worker infection rates between those hospitals who used N95s for all COVID care and those who used surgical masks. That's not to say that the N95s aren't more protective. Many of those healthcare workers got those infections outside of healthcare.
Right. And that seems to be a lot of the difficulty, where if we just say, as sensible people, the tighter the barrier that we place between ourselves and a pathogen, seems pretty logical that it reduces the chance of that pathogen getting through. Great. Okay, so we can start there. But then you go to all sorts of different studies and you have to contend with questions like, just because you have a mandate doesn't mean everyone's doing it. Just because people are doing it part of the day doesn't mean they're doing it all of the day. Just because you are ostensibly wearing an N95 mask doesn't mean you're wearing it correctly, or you don't have it pulled down or pulled up or, on your sleeve. So are those some of the difficulties in getting to what is the quote true answer?
That's exactly right. And that's really why the question is more than do masks work? It's, do mask mandates work, or does masking on a community level result in a lower level of infection transmission or number of infections than not masking on a community level? And what are you comparing it to? No masks at all, optional masking versus mandated masking. All of those things all of those comparisons are different comparisons.
Yeah.
And we have data that show that those broader sort of community level interventions are quite a bit less effective than you would want them to be, given that we do believe, although it is really hard to show with science, that masks are protecting us when we wear them. And some of the data evidence for that was also quite early on in healthcare. In looking specifically at SARS-CoV-2, what we were seeing was that healthcare workers did not have higher rates of SARS-CoV-2 antibody positivity. People who weren't healthcare workers, even though we were surrounded by COVID-19 patients all day long. And that was telling me that our PPE was working.
There's sort of a parallel, maybe we would call it an issue here, that is separate from a mask mandate, which maybe we can also introduce, which is, I've read a couple of studies which suggest that when news media is accurately informing people about the prevalence of a virus, meaning people are aware of when risk is higher versus when risk is lower, that people choose to behave differently, not only in terms of optional mask wearing in places like grocery stores, but also in terms of how social am I going to be? Am I going to go to sporting events, et cetera? So this would be the idea that it's less about mandating one thing or another, but that if people perceive, oh, there's a new variant, like for example, after Thanksgiving of whichever year it was when Delta first came, or whichever one it was, when people perceive the risk is higher, they will modify their behavior, and that this is a way that we actually do flatten the curve over a period of a couple of months. And so it's less about mandating, but more about informing, and that many people will actually make the choice that is logical anyway. Is that something that needs to be considered when the effectiveness is measured?
Yeah, that's exactly right. So, this gets to one of the CDC studies that was really instrumental in the development of their recommendations during the Omicron wave to shift to the highest quality mask you can wear instead of cloth masks, unless that's the highest quality mask you can tolerate.
Yep.
So the recommendation was N95s are the most protective, KN95s are the second most protective surgical masks, and then cloth masks. And that was based on this paper that they put out in their MMWR report, showing that people who used N95s, so people who tested positive versus negative for SARS-CoV-2 infection, COVID infection, were more likely to be negative if they had used a higher quality mask, essentially was the result of that study. And the critique to that is people who wear N95s are more likely to be COVID cautious in general,
right,
than people who choose, because that was not a randomized controlled clinical trial. And this is the critique for any observational study, any epidemiologic study, any study where you compare two geographical locations, for example. So there's a new study that shows that states and counties with mask mandates had lower infection in the United States, but not lower death rates, for example. Some of those things are exactly what you're saying. If you don't randomize in a randomized controlled clinical trial, and you just observe the people who choose to wear the higher quality masks, people who choose to wear masks over no masks are also taking COVID more seriously and doing those other things. The states and counties that choose to issue mandates are also issuing mandates related to other things. They may have more business closures. They may have more people in them that take COVID seriously.
right.
That's why the Cochrane systematic review, old and new, and really anytime they do a systematic review on anything, masks and treatments in medicine, will always focus on randomized controlled clinical trials, because that's the only way to take all those other factors out of the calculation.
If we want to, in sort of one sentence, give what might be the most comprehensive but also accurate assessment, is it fair to say that a correctly worn high-quality mask does a good job of protecting the individual wearing it, but mask mandates are less effective at protecting a population for all of the different reasons that you've cited so far? Like, is that kind of where we land?
That's what I believe to be true. I can't say that we have great data to prove prove that you wearing an N95 is definitely going to protect you from COVID-19. But that's what my 3+ years of experience in a hospital being bathed in COVID-19 tell me. Plus what I refer to as the seroprevalence data for healthcare workers, et cetera, the low rate of transmission that I see on a day-to-day basis, and it's my job to see that between patients and staff. So I believe that a high quality, well fitting mask will protect me if I wear one. But I agree with the second part of what you said, which is that I have been unable to see convincing evidence that a mask mandate or that community masking makes any difference in the incidence of infection. And the data that we have from 78 clinical trials suggest that if there is a difference there, it's very, very small. The epidemiologic data comparing county to county and state to state and country to country based on mask use suggests that if there's any difference there at all, it's very, very small. And that should really call into question the discussion around future mandates, in my opinion, even though, as I said, I've been trusting masks with my life.
There are all sorts of claims that we've seen over the last few years about the harms of masks. Sometimes these are what people call psychological harms related to kids in schools or being able to communicate or whatever the case may be. You then have the stuff like, well, it forces you to rebreathe your own carbon dioxide and all of these different things. And they've, to my relative satisfaction, mostly been all debunked, with the exception of it does seem that for little babies, exposure to an overwhelming number of people where they don't see their mouth when they are being spoken to may delay language development to some degree, and it seems to be temporary. I mean, I know I'm bringing a lot of new things in here, but on the criticisms of the masks, what do we actually know at this point?
Yeah, I mean, if we go back to when we first started to think about community level masking, which was in healthcare. So it's March of 2020. More and more of our healthcare workers are getting infected, generally at home and in the community, not through care of patients with COVID because they're wearing masks with patients. And we are, and they're getting exposed, and we're having to furlough them for 2 weeks. 5 minutes after we started to do that, we realized we can't run a hospital with the number of people that are home waiting to, usually not contract COVID after an exposure. We start bringing them back, and we have them wear, those who are exposed to COVID, we have them wear masks. So, very quickly, half of our healthcare workforce was wearing masks, but we didn't have a mask mandate in healthcare yet because masks had been shown in several meta-analyses not to be effective for that purpose. And that's why we had avoided doing that. But as I watched people wearing masks because of exposure, I saw a lot of people touching them, people putting them down on the table to eat on a surface that somebody else was going to eat on. I saw a lot of things that made me really nervous about having the conversation around bringing masks in as a long-term strategy, as a mandate for healthcare workers. But we did it. We did it because, it got to the point where everyone was exposed, and we needed to protect each other. And then, as you know, it became standard and recommended by the CDC for the whole country. The data on its effectiveness hadn't changed. The data on community masking hadn't changed between the CDC not recommending community masking and recommending community masking, but the stakes were so high. People were dying, and the hospitals were filling up, and people were going to be dying of non-COVID reasons because they couldn't get a bed in the hospital. And it was worth it. It was worth it to try. And I have to admit, I didn't have the creativity to think how we could possibly implement community masking on a national level, given the supply chain issues. I didn't think that people could make them at home, and I lacked that creativity, and I was wrong. We did it, and we did it effectively. But then what I started to see over time, especially as the children in schools were wearing masks, was, but also here in the hospital, working every day throughout the whole pandemic, was a loss of connection. When you couldn't see people's expressions and people's faces, you were just much less likely to, have those kind of intimate conversations. we were able to drop masks in the hospital in areas where patients and the public were restricted from entering. So
Mm.
after everyone was vaccinated in the summer of 2021, we stopped wearing masks in offices and conference rooms and break rooms. And it was night and day in terms of morale, combating burnout, and what we had just been through. And then we had to put the masks back on because the Delta variant was immune evasive, and people were vaccinated. People were getting infected
Yeah.
again, and it was hard. So I think that sure there are definite downsides when it comes to people who are hearing impaired, not being able to tell what's going on, people who are trying to learn language, people with speech impairments. And children who have developmental delays and that sort of social interaction piece. But I really did see amongst my children and my friends' children and amongst my colleagues just an impact on connection, mood, morale that has really improved again when we were able to take masks off about a year ago.
And last thing, the rebreathing of your own carbon dioxide does not seem to be a problem.
No, I wouldn't worry about that at all. And again, we do know that our surgeons wear masks for 16-hour cases, and there's no issue. So that would not be one of my concerns. Now, N95s, OSHA does require that that workers be medically cleared to wear N95 respirators.
Mm-hmm.
Those will cause shortness of breath. They can cause cardiovascular issues when you wear them for prolonged periods of time. And of course, we've all seen the pictures of the skin breakdown that you can have if you have to wear them for prolonged periods of time during a period where everybody has COVID or suspected COVID, which was the case in spring of 2020. So those can have some health implications.
All right. We've been speaking with Dr. Shira Doron from Tufts Medical Center in Boston, and also Chief Infection Control Officer for Tufts Medicine Health System. Really appreciate your time and your insights today.
It was such a pleasure.